may have an opportunity to type the comparison required. So I would invite everybody to join the items, then we can okay, then it's going to be more. Thank you for the question. Thank you. Very nice. Any questions? Mean between only local information and FIBI, or you can explain not only local. Is coming up. So what we have found out the most painful area during the screw insertion is the periodicity. So as an arithmetic here, everybody asks things primary principle in the rod, during the agility, there is a very important infiltration at the level of the periodicity of the screw insertion. Then we go from that. By the time we reach back and start putting junction, and then started taking it. And it was more to static side and everything. The other thing is to put the needle at the same other time. Wherein the liquid diffuses into the electron forming there. Now it is not like an exact electron forming block. We can go ahead and electron down and probably 2 minutes of running by electronics. We have found over a period of time that the amount of anesthesia with technique is good enough for us to carry out this. We don't want a certificate that we can start with a better plain block. We need anesthesia and anesthesia enough to carry out the procedure. That is what I am trying to emphasize. That is why we stopped running after the ultrasound guiding technique, and because we had ultrasound in India and various national was part of the community. We are so you give yourself time to this CM kind of blocks and plus local CM kind of a block. You just put the needle at the insertion site, then walk on the EP. The first thing you write is simple. So that's how much amount of local you use for the So what I use is have a special anesthesia cocktail for the scanning part of it. But when I come to the screws, to the 50% mixture of pure lignocaine with adrenaline. So 5 ml of lignocaine and adrenaline and 5 ml butyl. So lignocaine is for quick onset, shorter duration, and faster time. So I can start the procedure quickly. And then by the time the effect builds up, UPE is taken over, and this reduces the dose of both of them. So those are the tips and tricks we have evolved over a period of time. My question to Dr. Government is sitting here. Did you measure the amount of neurosis you actually after this transcripting technique, especially in multi-level technique? Because most of the cases you show, I think you actually neurosis. I have an answer to that. We don't in a 50-year-old or a 20-year-old, the neurosis is about 20-year-old. We want to have lordosis to the pre-symptomatic level. That is one thing. The cases which I showed in the first generation of the case, which was not lordotic. Now we have developed a lordotic kind of case. So when we put on the screws, we get a little bit of lordosis. But like I said, the aim is to get the lordosis back to the pre-symptomatic level, more or less than a 20-30-year-old situation. The Professor Bharati has also explained. If you compare it with the routine healing technique, how the lordosis will be achieved the time.
So it's a question now. First of all, I couldn't agree more with Varun. When you try to make your doses of ground in general, that is required for so much surgery that the risk actually outweighs the benefit. But if you try to restore it to a year or two before patient was symptomatic, that's the most suitable way of dealing with that. Now, the question about the numbers. We had a paper published about the scoliosis where you can, in preoperative CT compared to postoperative CT, you can correct 5 to 7 degrees like, you can correct up to 15 to 20 degree of scoliosis. Now, this is preoperative CT to postoperative CT. We know that in preoperative CT, you have an X amount of scoliosis. When they stand up, you add 30% to it. So it's good amount of lateral sclerosis. We have their paper that even I was going to present it, but unfortunately the document we presented wasn't available, which we did not present in the Camping Society. It was exactly about the deformity. By choosing the location of the cage, anterior versus posterior, right versus left, you can correct significant amount of deformity. So lateral scoliosis, the angle is about 5% and the posterior, I haven't published the data, but we are gathering those data. Literally with the MISSABCON technique, you can put the cage anterior to the fulcrum of the disc, and it seems like it can correct somewhere between 2 and 3 degrees per level. But that paper is not published.
So just one more question for everyone. Some lot of questions in the answer that I will give. Because we have been measuring the overall normalcy, that is going corrections. All the patients that we have done since last 1.5 years, in our data, we have presented this many only. Because we have done two things. One was the data only for the transplant that we have done. We have counted around 60 patients for transplant. And in 60 patients, we measured the segmental lordosis, the number of lordosis, and the discipline. The average segmental lordosis question was in 60 patients, we have got around 3.19 degrees of segmental lordosis. So that is what you can achieve. Then your next point, whether you want to go between OLLIF, when to choose OLLIF, and when to choose transplant. Because that's where the lordosis comes. So we have compared 50 patients of OLLIF that we have done, 50 patients of transplant. And for OLLIF patients, we are getting around 5.2 degree per segment lordosis. And we are getting 3.119 for the transplant patients. And if we compare between OLLIF and TILIF, that's what is our study. But TILIF gives around 1.9 degrees of segmental lordosis. This is what it's a normal segmental. Honestly, they are not only case here. So it's more. It is the best segmental lordosis correction. There is no doubt.
But only 82.
Please stop. Just so I say this is a new technique. It needs to mature. Maybe you will find better cases or better things which would make it compatible. But it's too early to say, and we're not achieving
We have all know that I think mastering the technique and then
yes, exactly.
yeah, exactly. Thank you, Varun. A very nice talk. So I would like to cover a bit of practice again for talk about
Great job. Thank you. Yes, please.
The last one.
So while you're setting up this, I like to emphasize that obviously we were talking about OLLIF ATP, which can be like anyone, you have a huge change, and that the significant correction of lordosis is very representative. And I'm happy to hear that your number, about 2.8 degrees, as well for my experience so far, about 2 to 3 degrees. And certainly with a smaller cage, the correction will be as well limited. So in the last segment, I'm going to talk to you about some advanced technique. People ask me about the indication for transcameral OLLIF. And before we get there, I want to tell you that the experience that most of us had here, thank you very much, that experience is that there is no procedure without side effect. There is no procedure without complication. And once you start doing that, once you go to your community, you are still the minority. People who have 10% permanent deficit will criticize you for your 10% temporary deficit. And let me repeat that. Once you start doing that, I don't care in what community, people who have 10 to 20% permanent deficit will criticize you for that 10% temporary deficit that we all had when we started this procedure. So you have to be prepared to gather your data, show that they are temporarily, and as well advance your technique, get more used to it, and based on how many of these advanced tools you have in your toolkit, then you can increase practically the number of the cases you can do safely. Now, these slides are going to be many different advanced techniques, but I want to concentrate only on one of them to stay within the time. And that is the so-called the transfer failure. We are familiar with the anatomy. I'm not going to go through all the preliminary thing. I'll just concentrate on maybe a video. You understand, we get there, we do the discectomy, and what's important, the same tool is used. People who have done prone lateral, they know the regular prone lateral, just the retractor system comes in two boxes, two big boxes. Yet, non-prone lateral, again, this is all we need. So, and in the advanced technique of so-called transfacet, which we published a paper just last year, practically you are drilling the hypertrophied part of the, and coming back to you, Warren, you can do discectomy. You can do a very good discectomy. So, and again, here you see the position of the cage is not by chance. It's eccentric to correct for scoliosis. I'm just going to jump fusion and so on. I'm going to jump literally to the so-called transfacet approach. And there is a video, instead of talking about it, I just want to show you the video. So here it is. In the transfacet, practically what you are doing, you are using a step drill to remove the lateral part of the facet, which is practically not the actual facet, is the hypertrophied part of the facet, to get approach to Cambin triangle. Now, again, I know there are lots of words used for this procedure, and my take on that is, as long as you do transcambin, call it EndoLIF, call it tubular TLIF, call it KLIF, call it OLLIF, and so on. The name doesn't really matter. What matters is that you're literally using Cambin triangle. In that case, you will be in the retroperitoneal space. In that case, it is what Dr. Cambin described it. Approach extraforaminal through the Cambin triangle, which, by the way, it is not foraminal. Your entire surgery will be outside of the foramen, so it is not really a TLIF by definition. But in this case, practically in a two-step drill, we identify the trajectory. You will see the X-rays. I have enough time to show you entire video. We fix a small drill in the AP and lateral to a trajectory that takes you from the facet all the way to inside of the disc. Then we drill this trajectory. And by the way, we are neuromonitoring this. This is, again, you cannot do this surgery without neuromonitoring. At this point, I'm stimulating at 10 to 12 milliamp. I used to do 12 milliamp. Now I went down to 10 milliamp. So in this entire process with small drill, big drill, and two stepwise following each other is done under neuromonitoring at 10 to 12 milliamp. Once you do these stepwise drills, practically you have established a path through the Cambin triangle from outside to the disc. Now, your advantage is, if this really doesn't show it, the advantage is that the axillary of L5S1, by the way, 90% of my transfacet OLLIFs are done in 5S1. This is one of my rescue techniques. I tried the OLLIF, if it doesn't work. I tried the MISSABCON. If that doesn't work, I do use this technique. So the last time I converted the OLLIF case to open case was 4 years ago, because I have multiple backup techniques to use that. Now, here you see once we are in the place, then we use the regular technique. You see the stepwise, the small drill goes in. Again, neuromonitoring is done. And if you don't get a response at 10 milliamp, practically your profile, safety profile is the same, exactly the same as regular OLLIF. So the small drill, the big drill, and the two, they follow each other. And Varun, this is one of the next thing I'm going to bring you next time I come here. because this is very easy steps, and it's a small, both cannulated. They're all cannulated, small drill, big drill, and then the tube follows. And then once you are there, the rest of the surgery, obviously, exactly, you don't want that happen in the actual surgery, but it won't, because there's a tissue that's holding it back. So, but for demonstration purpose, let's look at the actual X-ray. There's only a few minutes left here. If I have time, I just want to go, let's show a video of the transfixed OLLIF. It takes less than a minute. So, for the X-ray view of the procedure. So here, you're going to see first, I did try the regular OLLIF. I have 1 minute time. So, but I'm going to go forward. Once I fail to find the electrophysiologic silent area, then I literally put a small drill. I fix the trajectory in a lateral that I get in the direction of the disc. And then the first, you will see that I dilate. Then after that, I'm going to go forward. This is probably still our old system where I use a drill and a dilator, stepwise, drill a little, tap the dilator right next to it, drill a little, tap the dilator next to it, until you're in you're through the facet. Here you see that again. Once you're through the facet, then I put a K-wire, put a dilator, and I go in, and the rest of the surgery is the regular OLLIF. Now, with the new system, the small drill goes all the way in under 10 to 12 milliamp. Then the big drill, again, on the neuromonitoring goes all the way in, and the tube follows. Now, what you need to know about the anatomy of the L5-S1 is that you have practically S1, S2, S3 already separating. They don't come straight down. They come in and they go up before they go through the S1 foramen, and L5 goes lateral. So the axilla of the L5 and S1 is a ginormous space. And in the AP films, you see you are very, very medial. There are two things important. You are neuromonitoring it. Don't be afraid of that. Even though you look medial, the nerve root, you're not pushing the nerve root. The nerve root is above because it's taking off, going up because of the slope of the sacrum. And then obviously the L5 is very lateral. And another thing I think what's important, because you are going straight down, you can go all the way forward and put the cage in the middle, right in the forward, which as well help you with some of the lordosis, okay? So thank you very much.
Yeah, thank you, Dr. Abadi. A very nice presentation. So this is the last lecture of this session. We can just take one question if anyone has to any of the speakers. Yeah, so just one question, the last. Nice presentation. I just want to have one question. Do we see this side into Dr. Varun also? Do we need to assess the foraminal dimension on this side before planning this? Varun, can you take the case design if you're using different from the regular plant of the end, even people are trying to force that case to start something the problem. You can notice the paper is not what is yeah. It is right? So as it goes, you can taking the things away. Yeah, but when there is a space for everything you to push away, then it is not. For remaining height is small. So we don't expect that when you are pushing the space that the boot will be like it may get damaged. Yeah, so our things to get it first thing is the dilator. If you can get the dilator in safely, you can at least get an 8 you can take 3 weeks. Right?
Yep. If I may answer that, do you mind to share my screen? I answer it to you with a 30-second video. The answer to that is absolutely you can do that. We need to have some experience. If you just Google impossible OLLIF, I just put it impossible OLLIF so it's easy to find. Just go to YouTube, put impossible OLLIF, and you get the two cases that you can see that when you master the technique, you can enter the, no matter how collapsed the disk is, you can master that. And I'm just going to show you video, but watch the other one as well, where even in the most collapsed cases, even with the osteophyte, once you master the technique, once you get into the disk base, practically dilator helps you to open up that space. All you need to do is to get the K-wire in that is dilator can safely follow. In some cases, like a Seldinger technique, in one of my advanced technique that I didn't show is that I put a small little bend into the tip of the very small bend in the tip of the K-wire. Then I can put a coker strong on the K-wire. By rotating the K-wire, I literally, even I bypass the osteophyte, turn the direction, go inside of the disc. Even in those cases where it's totally covered, you really can do that. So please go YouTube these two, impossible OLLIF, and then OLLIF plus so-called directional K-wire. And if you do that, you see that, and it's easier once you master the technique. It's so much easier than you think. So look for these two videos.
Dr. Abbas is available here to all my doubts. I would really like to thank all the speakers, Dr. Abbas, Dr. Varun, Dr. Christian, and Dr. Dekosa. So we now
And we can go.